My name is Dr. Ndambi. I'll be the moderator for today. So today we are covering, the theme for today is pediatric ENT manifestations of pediatric malignancies, and then we'll also cover ALL, pediatric hematological malignancies. So our presenters for the day, we have Dr. Austin Oyer. He's going to cover the ENT bit of pediatric malignancies. So he's an ENT surgeon at Nakuru Level 6 Hospital. He's specialized in ENT. Then our second presenter is going to be Dr. Gilbert Olbara, who is a consultant pediatrician at MTRH, currently a pediatric hematology and oncology fellow at MTRH. He has additional interests in clinical research. His areas of interest are childhood cancer, improving childhood cancer outcomes in low-resource countries and health systems. So I just want to welcome you all. We're going to have a Q&A session at the end of it all. So kindly type your questions in the actually in the Q&A section so that we don't miss any of them. If there are any concerns, kindly raise them in the chat box. I think the first presenter can now begin. Thank you.
Dr. Austin, are you taking the first one?
Afternoon. I assumed my pediatric colleague would take the first one, but it's okay. I can begin. However, my part is quite short. It's okay.
I can start, no problem. I thought, okay, I can start. Let me share my screen.
All right.
No problem, no problem. Good afternoon, everyone. I hope you can see my screen.
Yeah, we can see the screen. Maybe just test so we can see whether the slides are moving.
Okay, this should be the second one and
Yeah.
the third.
Yeah, that's cool. It's working.
Okay. Okay, my name is Dr. Olbara Gilbert. Thank you, Dr. Austin, and thank you for the introduction, KNH team. So I'm going to talk about acute lymphoblastic leukemia, and I purposefully took up the title, this is as an overview for all of us. So whether we are a nurse, hemato-oncologist, or pediatrician, or ENT, this is just to remind us about acute lymphoblastic leukemia. So my objectives are just these three main objectives, just to review leukemia in terms of the signs and symptoms, to make a diagnosis, to remind us how to make a diagnosis, And then I'll highlight some of the studies or research that has been done in Kenya to highlight the treatment and outcomes of acute lymphoblastic leukemia. So first things first, I start with reminding us that leukemia is actually the cancer of the blood. And more specifically, it's the cancer of the cells of the blood. And we are going to look at why we say this is true. Then the second key point in terms of my introduction is that leukemia is very curable. I know when we talk about malignancies, we think of something that is not very curable. It's a death sentence for the parents. But studies have shown actually if you have 8 children and if you have 10 children, 8 out of the 10 children are supposed to be cured of leukemia completely. So 80% cure rates. In terms of how common it is, 30 million cases per year. These are based on Western studies. 30 million cases per year. For example, in Western Kenya, where I come from, there are 10 million children based on the census that was done most recently. Out of these 10 million children, we are supposed to see 300 children with acute lymphoblastic leukemia every single year. Then the other type of leukemia is acute myeloid leukemia. And this one also, I just put it there because it also presents with a lot of bleeding, particularly epistaxis, nose bleeding. But this is less common, 8 cases per million. In terms of presentation, 90% of the patients will present with a hemogram HB that is less than 11 grams per deciliter. And half of these patients will present with a HB that is less than 7 grams per deciliter. This is just to say that this is the most frequent presentation or sign. So let's delve into the deep end. Let's go more into the science of leukemias. So leukemias are defined as clonal proliferation of the hematopoietic cell lines. These are cells in the bone marrow, and as a result, it releases abnormal cells into the circulation. So the problem is primarily at the bone marrow level, where you have abnormal cells being released, first proliferating or increasing in number, thereafter being released into the circulation. Based on the clinical presentation, you can have an acute disease or you can have a chronic disease. Acute disease usually is rapid in terms of progression and onset. And if you do not treat, if you do not do something, death occurs within 2 to 3 months. However, chronic cases are more insidious and the patient may present with the disease for up to several years without fatality. In children, 90% to up to 80 to 90% of the cases are actually acute leukemia. Chronic is more common in older persons, that is in the elderly. This is just based on a study that was done in America, in North America. And we just wanted to see which patients or what are the trends in terms of the age of presentation. So this, we are looking at incidence of leukemia by age. What you can appreciate in this graph is that the ages between 1 and 5 are the most affected. As you can see, for both leukemia, for acute lymphoblastic leukemia, which is the blue one, the highest peak period is between 2 and 4 years. And then it starts going down as they approach their teenage or young adulthood. And this graph on the right actually signifies that you have a very high peak or common occurrence of acute lymphoblastic leukemia in the first 5 years of life, then it goes down. For acute myeloid leukemia, it is different. It increases with age. So in the 5th and 6th decades in adults, you are likely to see more AML, but it's much less in the younger period. So a little bit about the statistics or the numbers. We've already looked at this. Peak age is between 2 and 4 years. For some reasons that is not very well explained, boys are more affected than girls. Then globally, it accounts for 30% of cancer diagnosis in children less than 19 years of age. So if you deal with acute leukemias alone, you've already dealt with 1/3 of the childhood cancers. If you add acute lymphoblastic leukemia to that, you've already dealt with half of the cancers in children. It's most common cancer in children under 15. In Kenya, we are supposed, in Kenya, we should see about 250 children per year. However, only 25%, that is about less than 80 children arrive at our facilities, both at Kenyatta, at treatment facilities, both at Kenyatta and MTRH, and sometimes in Mombasa. So we only see 25% of what we are supposed to see, meaning 75% of the children don't reach a treatment center. They are out there in the community. I put this just to show us that these are based on what we have done in MTRH, and you can see children with acute leukemia in America are the same as children with acute leukemia here. The peak age also at MTRH is between 0 and 5 years, as you can see by this blue part in the pie chart. Then we just highlighted where in Kenya, or which counties most of our patients are coming from. Nakuru, Bomet, and Uasin Gishu were the highest, with Nakuru having 20 patients in the period that we did the study. In terms of whether it is B cell or T cell, 85% of the acute leukemias are actually B cell in origin, and we're just going to highlight this in the next few slides. T cell ALL is more common in the adolescents and mostly will present with mediastinal or respiratory symptoms. The clinical picture in terms of presentation is, however, quite similar. It's very difficult on clinical picture to differentiate B cell and T cell ALL. So what are the risk factors? That is a common question we get. What are the risk factors for acute lymphoblastic leukemia in the common population of children? So number one, only 10% of the cases have an association. So the rest, 90%, don't have any specific associations. In terms of this 10% with associations, a few things have been identified. The first one is genetic. So children, for example, with trisomy 21, which is a chromosomal abnormality, have about 20 times a higher risk than other children. Then there are things like neurofibromatosis, Fanconi anemia. Fanconi anemia, children with Fanconi anemia, which is a type of blood disorder, are likely to develop acute lymphoblastic leukemia because either of the treatment or because of the genetic abnormalities that they have. Then there are a few environmental factors that have been studied. They are still controversial, but have been mentioned. Some drugs and chemicals, especially industrial chemicals like benzene, has been studied over a period of time, and it's still controversial, not very clear-cut association. Some pesticides, so maternal or parental exposure to pesticides has also been studied, and I think there are a lot of works that are being discussed about it, but there's no clear-cut associations. Then ionizing radiation. So in some studies, they've tried to look at those communities that live under a high voltage electrical transmission lines, but also the outcomes are not very clear, but it's one of the environmental factors that has been associated with leukemias. Then immunosuppression, HIV, some immunological disorders have also been implicated. But the take-home message in terms of risk factors, 90%, there's no associated, it's just a sporadic occurrence. As a hematologist, I like this picture, and I usually call it Father Abraham. This is just to highlight the pathogenesis of acute lymphoblastic leukemia. And what we see here is the hematopoietic progenitor cell. It's the Father Abraham that actually gives yield to all the cells that we see in our bone marrow. When we come to the left here, we see the lymphoid progenitor, and that is where you get your B cells, T cells, and NK cells, which are basically the cells of the immune system. And this is where actually leukemia as a problem occurs. Acute lymphoblastic leukemia is actually a problem of the lymphoid progenitor. It can either be a B cell or a T cell. On your right, you have the myeloid progenitor, which gives rise to the red blood cells, which is responsible for anemia if it is in short. The platelets, which is, I think, Dr. is going to talk about it, because the platelets are actually responsible for bleeding or preventing bleeding, and then the cells of the immune system, the neutrophils and the macrophages. So leukemia as a process is mainly problem of a lymphoid progenitor, either B cell or T cell. So what exactly happens at a molecular level? So this is the B cell or T cell. Ideally, this B cell or T cell is supposed to differentiate, and when it gets old, it's supposed to apoptosis, which means it is killed so that new cells can come into the tissue. When it's worn out, it is killed in this immune system so that new cells can come. So what happens in acute leukemia is that they lose the capacity to self-kill, to kill themselves when they are old or when they have senesced, and therefore they continue proliferating. The other thing is they lose the capacity to differentiate. A B cell should differentiate into a mature B cell, which is a cell of the immune system. So when this failure of this process occurs, then it can continue to proliferate and increase in size in the bone marrow before spreading into the rest of the tissue, giving us the signs and symptoms of acute lymphoblastic leukemia. So this proliferative and survival advantage is what actually underlines the acute lymphoblastic leukemia. So they are just normal cells which have failed, which continue to grow without control and causing infiltration of the normal tissues. How does a patient with acute leukemia present? First, you have the general systemic effects. Fever will occur in about 60% of the patient, and then pallor, which is anemia, or anemia will occur in 40% of the patients. Then, apart from the general systemic effects, which are very common, you can see in any other disease, you have some specific signs which are hematological. So first one is anemia. So these are patients who will become easily fatigued. They are not, if it's a child, they are not able to run around or participate in the normal play of a child. Then neutropenia. So this is characteristically that child who comes to hospital every other week. If today is a pneumonia, tomorrow they have a cough, tomorrow they have ear discharge. So signs of neutropenia. Then thrombocytopenia, this is bleeding either from the skin, from the nose, which we are going to discuss subsequently, or mucous membrane. And sometimes they may have intracranial bleeding in the head when they have spontaneous. The other clinical manifestation is actually infiltration of other organs. So you have lymphoid system infiltration where you have enlarged lymph nodes, enlarged spleen, and enlarged liver. Bone and joint involvement is something that I want to emphasize. Sometimes this patient can present with bone pain as the only symptom. So this is a patient who's not been hit, has not fallen, doesn't have a fracture, but they just have very severe bone pain. And these are the reasons why they're having this bone pain, because the tumor cells are infiltrating the periosteum or it's causing infarction. The other aspect is CNS disease, which is quite uncommon, either as signs of raised intracranial pressure or parenchymal involvement. In parenchymal involvement, you may have actually cranial nerve pulses. They may present with convulsions, or if you have cerebellar involvement, they may have changes in gait. And these are the other systems: genitourinary, gastrointestinal involvement, which is sometimes not very common, and cardiac and lung involvement, also not very common. But they can all occur. In leukemia, it's a multisystemic disease, so all these systems can be affected. It's good to evaluate. So lest we forget everything, this is just an image to remind us which symptoms: the systemic symptoms, weight loss, fever, frequent infections. The lungs, especially the T cell, you have easy shortness and shortness of breath. The skin, you can have the petechia or the bleeding. I know we always say it's sometimes difficult to see in our black skin, but if you see purplish spots or reddish spots on the skin, then think about subcutaneous or cutaneous bleeding. In summary, what we take home: 4 P's of leukemia. Pallor, a patient requiring transfusion here every other time they come to the hospital. Think about leukemia. If the patient is coming with pyrexia, that is a sign of recurrent infection. And these fevers in patients with acute leukemia are those fevers that are not very, very high, but this patient has a 38, 39 and doesn't look very toxic. Remember, when you have a patient with acute malaria, for example, and they have a fever of 38, 39, they will look very sick. But these are patients with pyrexia. They have this fever for a month or so, and it's not very high, and they don't look very toxic unless they have the other symptoms. The other P's are purpura, so bleeding on the skin, and pain. Remember, pain can be the only manifestation, especially if it is a bone pain or joint pain that is resulting in change in gait. So how do we make a diagnosis? Number 1, look at the hemogram, look for anemia. We say the most common sign is anemia. And this will increase when you have these other symptoms. If you have anemia plus any other of the blood parameters is affected, which is a pancytopenia or bacytopenia, meaning the neutrophils are affected or the white blood cells are affected, they are suppressed or they are very high. And secondly, if the platelets are very low or usually very low most of the time, then suspect leukemia until otherwise proven, especially if the clinical picture is fitting what we've discussed. This is just a repetition of the same. We will do a CBC and a PBF to look for blasts. Then we'll do blood chemistry to look for electrolyte imbalances because of the very high white blood cell counts. You can do an ultrasound in most of these patients. First, palpate the testicles and look at whether they are enlarged. But the definitive diagnosis is actually doing a bone marrow aspirate, where you look at the morphology of the cells to look at the blasts, immunohistochemistry, and immunotyping. This is just how the bone marrow or the peripheral blood film of the patients will look, and we look and find these large cells here, these large cells that are so many monotonums in the peripheral blood film. The red ones here with a whitish spot are usually the normal red blood cells, and these are usually suspected to be the platelets. So when you see these large cells, the pathologist will tell you this patient is likely to be having blasts in the peripheral blood film, and this is a patient that is indicated to have a bone marrow done. Management, I will not emphasize so much on the management, but the most important is supportive care. It's not actually the chemotherapy, but supportive care. Consult the patient in terms of the diagnosis, the side effects of the chemotherapy. Their treatment is going to take 2 years, so they will require hospitalization. NHIF, they cannot afford this care, and they cannot afford to continue treatment for 2 years if they don't have a way of paying for the services. So encourage them or advocate for them to get an NHIF, and they will get this treatment in a treatment center, and it will be covered under an insurance scheme. Other things are antibiotics and antifungal. We give them Septrin because we prophylax against PCP. Nutrition is very important. Put or call in your nutritionist, because even before you start your chemotherapy, optimizing their nutrition is quite important. Then the take-home message here, early consultation, early referral. From your PBF, your bone marrow, or your CBC, you suspect a leukemic process, refer. Consult KNH, consult MTRH, or consult your seniors so that this patient can benefit from early treatment. Definitive management, just a summary. We use chemotherapy specifically. In acute leukemia, there's no role for radiotherapy, there's no role for surgery. We have 3 phases. Remission induction. Here we aim to eradicate the leukemic cells. Usually it lasts for 6 weeks. Then we have a consolidation phase and a maintenance phase. Every treating institution has its protocol, but the main aim, irrespective of the treatment center, is to reduce the blasts before emergence of drug resistance. The total duration of treatment is usually 2 years. So finally, I want to look at the outcomes of acute lymphoblastic leukemia. First, we look at the outcomes in North America, because they've done these studies over several years since the 1960s. And what we see is that if you look at where I have highlighted in the 1970s, in 1970s, using the kind of treatment they were having, their outcomes was 20%. So out of 10 children, only 2 were surviving. However, they made some changes over this period of time, and you can see in the later aspect of the 1970s, they went into 60%, and the current rate is more than 90%. So 9 out of 10 children are surviving acute lymphoblastic leukemia. At MTRH, we looked at our data from 2010 to 2016, and what you see is our outcomes are just slightly below 25%. So where we are at MTRH in 2016 is where US people in America were 70 or in the 1970s. However, what we have realized is that the drugs that we are using currently is what they were using in the 1975 or the 1970s. So ideally, we are supposed to have an outcome, we're supposed to have an outcome somewhere here in the 70s, just using the medication that we have currently. So there are other factors that are actually contributing to this poor outcome, which is not actually the treatment. And that is what I want to highlight. In Kenya, the current status, these are actually the reasons for poor outcome in Kenya. And what you see, the biggest outcome, accounting for 90% of poor outcomes, is actually that these patients are not being diagnosed. The other things are misdiagnosis, or the parents refusing treatment, or once we've started treatment, the children die because of the toxic death. But the biggest culprit is actually no diagnosis. And that is why I focused our presentation today to focus on early diagnosis and referral. So what we can do, one is educate our colleagues, like what we are doing today. For example, a project ECHO that we are doing in Western Kenya, so that we can reach as many healthcare providers as possible and learn from one another how to make a diagnosis and how to make an early referral. This is just an example of telemedicine, where we discuss a topic like we have done today for 20 minutes, then we discuss cases, and then we advise colleagues from the peripheral facility. How it works is that if this is MTRH, then we have counties that refer patients to us. We discuss patients in those counties before they refer to us, and we learn from the counties, and we as MTRH or the counties learn from MTRH or a treating center like Kenyatta National Hospital. So finally, that is the end of my presentation. Thank you. I welcome any questions.
Thank you very much, Dr. Olbara. That was very enlightening and eye-opening, and myself, I've learned a lot. So I just want to welcome any questions. It would be easier to type the questions in the Q&A box. I don't know if the attendees are able to access that. So it will be easier to type them in the Q&A box, and then we answer them as we go. So kindly, if you have any questions, kindly type them in the Q&A box, and then we can tackle them together also after Dr. Austin's presentation. Then we can just go through all the questions together. I hope that's okay with everyone.
I think that's fine by me. Dr. Olbara, thank you so much for your presentation. I would like to now begin sharing my screen and do my part. Thank you.
Okay, now I've stopped sharing. Dr. Austin.
All right. Thank you.
Thank you.
Can you see my presentation?
Not yet. We can't see it just yet. I personally can't see it.
All right, let me just try again.
Yes, now we can see.
All right, I'm using a device here. You can see it?
Yeah, we can see. Just try move the slides, then we see whether it's all right.
It's
Yeah.
moving?
Yeah.
All right. All right. So good afternoon again. Thank you again, Dr. Olbara, for your wonderful presentation. My name is Dr. Yuer Austin. I'm an ENT surgeon here at Nakuru Level 6 Hospital. So this is a brief outline of my presentation. We'll look at the malignancies, how they present, the complications they have in regards to ENT management, a take-home message, and some of my references. So the malignancies that usually have ENT manifestations are mainly the leukemias, lymphomas. Some have the soft tissue tumors and the thyroid cancers, but the ones with hematological presentation are mainly the leukemias and lymphomas, and that's where our presentation will be based today. So in terms of leukemias, these patients usually present mainly with infections which are ENT related. For example, one, they'll present with a tonsillar abscess or a cellulitis, and this patient will have like a swelling around the tonsillar region. They might even have lymphadenopathy, so you might notice some swelling on the neck. They might complain of difficulty or even painful swallowing. They might have difficulty in breathing, and difficulty in breathing is now when we usually come in, because in the acute setting, with a tonsillar abscess, with a difficulty in breathing, the fever, we'll want to treat it first. then now drain the abscess and also give antibiotics. Some will also present with sinusitis, so they'll have the characteristic facial pain, facial kind of like heaviness, facial pressure. They might have headaches, they might have a fever, a nasal discharge, either mucoid or even sometimes it's a pus discharge from the nose. Can be from one nose, could be from both sides. And this is usually, we usually called in probably after the patient has had a CT scan done and it's reported as the patient has sinusitis. So then an ENT consult is sent. But as you can see, the complications are quite life-threatening. They might develop meningitis, intracranial abscesses, might have orbital extension of these sinus infections, which would lead to even an orbital abscess and even infections right down to the optic nerve, which can be threatening to the vision of the child. So then would come in with our antibiotics, analgesia, intranasal steroids, and most importantly, nasal douching just to wash out the debris and the bacteria. Then later on, after 5 days of antibiotics, if need be, then we might end up doing FES, which is our functional endoscopic sinus surgery. So facial cellulitis, a similar picture with the swelling, pain, and fever, usually after an infection of the maxillary sinus. So as an extension of maxillary sinusitis, and they might have similar complications treated mostly by antibiotics and analgesia. Then acute otitis media or otitis externa may also develop. These patients have a lowered immunity, and these are some of the predisposing factors to infections of either the middle ear or the external ear, or even the mastoid cavity itself by extension. So they would have the characteristic ear pain, ear discharge, a fever. They might even complain of a hearing loss, or you might even notice a swelling just behind the ear. And their complications are also quite serious, which can be meningitis. An abscess might develop, an intracranial abscess. They might even develop facial palsy and labyrinthitis, which will give them more of symptoms of dizziness, nausea, vomiting, and the likes, which is also treated by antibiotics. Analgesia will do a lot of oral toilet, so we'll be cleaning the ear frequently. We'll give ototopic antibiotics, and then later come on and do our mastoidectomy once the infection has gone down. So epiglottitis is also quite common, and these patients will usually complain of difficulty in breathing. They'll have a stridor, they'll have a change in their voice, they'll be drooling, the child will assume a sniffing position, might have the fever, characteristic dysphagia or dinophagia. And usually what we're concerned about is the difficulty in breathing. They might develop aspiration or even IJV thrombosis or even pericarditis. So these ones will also treat aggressively with antibiotics, analgesia, steroids, and even drain an abscess when it develops as a parapharyngeal abscess. Bleeding is also one of the complications that these patients experience, and it's usually bleeding in terms of epistaxis, but they might also experience bleeding into the middle ear or inner ear, which might go unnoticed, but the epistaxis is usually noticed. And we know, as we've seen, the patients can actually go into anemia or even worsening of their current anemic picture. They might go into shock. They might even develop hearing loss, especially if they have bleeding in the middle ear and in the inner ear. And here we usually come in to do our nasal packing just as an emergent measure to stop the bleeding, at least conserve some of the blood, as we work with our pediatric colleagues to ensure that the patient is transfused and other management is implemented. So the images you're seeing, the first image on the left is of the tonsillar abscess. You can see the left tonsil is quite swollen and it's full of pus inside. The second image, you can see there's a swelling behind the child's ear, and that's usually characteristics of a mastoid abscess. The third image being a CT scan, an axial view showing our peritonsillar abscess, which might have complicated from either even the mastoid abscess or even an epiglottitis infection that we have seen. Then epiglottitis on the left, the lower image on the left, you can see the image A is of the normal epiglottis and the larynx. You can clearly visualize the vocal cords, the epiglottis quite well. Then image B is now when the patient has epiglottitis, and you can see it significantly narrowing the airway. So lymphomas are also the second commonest that will be called for ENT reviews, and we see they usually present as a neck mass. Usually any patient who presents with a neck mass will be referred to the ENT side, and these patients might even complain of things like dysphagia. They might have otitis media, so they might still have the ear infection, so they have a discharge, ear pain, hearing loss. They might have odinophagia. They might have airway obstruction. And we have seen commonly, you have the non-Hodgkin's lymphoma lesions, which will affect the Walde's ring sites, which are your common sites for the lymphoid tissues. And the tonsils are usually commonly affected. As you can see the image, and you can see the right tonsil is actually quite swollen. Other areas that might be affected might be the base of tongue, the nasopharynx, the posterior pharyngeal wall, or even the nose where you have the adenoids. Those ones might also be affected, and even the paranasal sinuses. So I kept it short and sweet. Our take-home message, it's like emphasizing what Dr. Albara says. We need to ensure there's early recognition and early consultation, prompt diagnosis and early treatment, and prevention of the complications. As we've seen, they can be quite dire. These are part of my references, and thank you very much.
Thank you very much, Dr. Oyer, for the surgical aspect of it. Really appreciate that. Quite enlightening. There's some things we see, and I don't think personally I'd have thought that far, but thanks very much. This is eye-opening. So I'll just open the floor to questions. I can see a few in the Q&A section. I think most of them are for the initial part of the presentation. So I can just read them for Dr. Obara, and then he can answer as we go. So there's a question here from Dr. Ndungu asking which drugs are currently available. I think that's for the treatment of ALL.
So thank you, Dr. Ndungu. I think that's an important question, and I'll take that together with another question that has been raised. So the first one is that almost all the primary drugs for acute lymphoblastic leukemia are actually available in Kenya. And that is in the public hospitals through KEMSA. So all the drugs that are required are actually available. So why I said the drugs for 1970 is that what you realize is that the chemotherapy for acute lymphoblastic leukemia has not changed much between 1970 and actually up to the year 2000s. It's only recently that we started having the immunologicals or the targeted therapy. But the conventional chemotherapy, all the available drugs, all the required drugs are actually available in Kenya. So what we are missing are things like now the CAR-T, which are just new drugs being released in US markets recently. But all said and done, these drugs that I'm saying are available in Kenya that are actually sourced through KEMSA, our hospital is getting them through KEMSA, actually should be able to give us an outcome of more than 70% in Kenya. Then the second question that goes with that is that the part where you talked about chemotherapy, there was a question about antineoplastic, when is it indicated? For acute lymphoblastic leukemia, you start antineoplastic or chemotherapy as soon as you start, as soon as you've confirmed the diagnosis, counseled the patient and consented them in terms of chemotherapy. The mainstay actually of treatment is chemotherapy. So we start as soon as we've made a diagnosis, as soon as we've consented the patient and counseled them. So that is to answer the question that was raised about when we start the chemotherapy. What I just highlighted is that in acute leukemias, you don't need radiotherapy, you don't need surgery. Most of them are cured with chemotherapy.
Thank you very much, Dr. Albara. I can see another question from Mary. How much will the latest treatment for leukemia cost? I think she's asking, like in the US, how much would it be for a patient?
A carefully guarded estimate is that in Kenya, the total cost, I think we tried working it out. If we do the total cost for the whole 2 years, is between 600,000 and 700,000 using the conventional medicines that are available at the government prices or at the prices. Usually it's about 600,000 for 2 years. That is to cover all the treatments costs, that is the medication, because the cost of chemotherapy is a bit expensive. What is expensive are the new drugs, which may cost anything between 1 million or to 2 million, but that is a guided estimate of how much it may cost in the private facilities. It varies, and also when you go to a place like United States. But even them, they use mostly the same drugs that we use, only that for those patients that have very high risk is when they add now the new model of drugs, or those patients who relapse after the first treatment is when they add the new additional drugs. But all the drugs that are available in US, most of them are also used in this facility for the conventional medicine. So I think that answers the question in terms of cost.
Yeah, thank you. Just a question from myself. Are the costs of treatment for leukemias covered by NHIF, or is there like a co-payment from the patient's family?
So in public facilities, thank you for that question. In public facilities, it's actually fully covered by NHIF. When I talk about 500 patients who come to MTRH, and I think the same is also at KNH, as long as those drugs are available in the treatment facilities and the patient has NHIF, all the costs will be covered by NHIF. And I am aware that NHIF as an organization is also working to improve the oncology service package. So there are actually ongoing talks to actually improve the oncology service package. I think the part where it was not covered very well was the diagnosis in terms of the bone marrow, the CT scans and all those, and I think they're trying to improve. But for the chemotherapy, everything is usually covered and the patient doesn't have to buy or pay or co-pay any extras.
Okay, thank you very much. There's a question there from James Rotich. Can flow cytometry confirm ALL as much as BMA should be done? I think he's asked about whether BMA or flow cytometry, whichever is better for confirming ALL.
So that's a very interesting question, James. So for diagnosis of ALL, as we mentioned, first you start from the history physical exam, then you go to the peripheral blood film, and the mainstay of diagnosis is looking for blasts. So there are two ways that you can look for blasts. One is by flow cytometry, it can actually show you, and the other one is morphology, looking under the microscope. So to answer that question specifically, most recommendations actually recommend you need to do both flow cytometry together with bone marrow. You can start your treatment based on the flow cytometry, but you need also the bone marrow to confirm so that they go together. What has been shown is that when you do them together, it improves, one, confirming that the patient has ALL, and secondly, it helps you to actually break down which type of acute lymphoblastic leukemia, whether it's a high risk, low risk, whether it's a B cell or T cell. So you actually are recommended or advised to do together, but you can start treatment based on a flow cytometry diagnosis.
Okay, thank you. There's another question from Samuel Okello. Is there a difference between the anemias of ALL and AML?
Yes, so both of them, as I showed you, originate from one is a myeloid, so one is a myeloid, one is a lymphoid. So in terms of the presentation, the clinical picture, they are quite very different. In terms of the treatment also, it's very different. So both of them, you have to actually differentiate whether it's an acute lymphoblastic or an acute myeloid. In fact, Dr. Austin will see more of the acute myeloid patients because they tend to bleed so much. It tends to occur with a lot of bleeding, especially epistaxis, mucosal bleeding. Sometimes the pharyngeal wall is actually so edematous. So sometimes we have to send them emergently to the ENT to work. So, however, the ALL tends to have bleeding, but is not as much as acute myeloid. In terms of the outcome, acute myeloid is usually quite poor and an aggressive disease. acute lymphoblastic usually is much better in terms of outcomes. So in terms of the clinical picture, in terms of the pathology, in terms of the outcomes, they are quite different, and the treatment is also very different.
Thank you. I'll combine two questions here. One is asking what is the level of genetic inheritance of leukemia? And the other one is asking at what age specifically would these symptoms be so profound?
Yeah, I think very scientific questions, I think. I have to think about it. So in terms of the genetic inheritance, so genetic inheritance, so people have tried to look at whether these acute leukemias, let's call them leukemias, are actually inheritable. You can inherit them. But from what we said, there are very few associations. The genetic, it's not an inheritable disease. You cannot inherit, or it cannot be passed down from parents to child, or from sibling to sibling. So that is the first aspect of it. However, in terms of twins, people have tried to look at twins, and they've seen that if one twin has acute lymphoblastic leukemia, there's a higher than normal chance of the other twin also developing leukemia. And this is because the genetic problem that is causing this leukemia is also shared amongst the twins. But in terms of the parent and passing it down to the children, that is very uncommon, actually. So I think that is the best way I can answer that. In terms of the symptoms of leukemia are actually initially very non-specific, and they can manifest at whatever age. It depends on the time of onset of the disease, of the leukemic process. So it can occur at infancy, it can occur at 5 years, it can occur at 19 years, depending on how soon or when the leukemic process starts. So symptoms are actually dependent on the onset of disease. What I can just mention is that initially, in the initial phase of the disease, these symptoms can look like anything. Bone pain, a patient presenting with bone pain and has leukemia can actually be confused for a patient with osteomyelitis. A patient with the early general symptoms of lassitude, anemia, and fevers presenting with in health facilities can actually be confused and treated for malaria. So it is very non-specific initially, but then as the symptoms progress, when you get lymphadenopathy, when you get hepatosplenomegaly, when you get CNS symptoms, then it becomes more clearer, the clinical presentation. But the symptoms can occur at any given time in the lifeline of a patient.
Thank you for that, Doc. I think I'll combine three questions here on treatment. There is a question asking the role of allopurinol in leukemia management, whether it's safe for all ages. There's a question asking, now that we are still at the 1970 treatment, do we have the current treatment available in the country? And someone would like to know why all patients are given prophylaxis for PCP, and for how long should they be on that prophylaxis?
So first, I'd want to demystify the 1970s. What I've said is that for all childhood cancers, is that the development of childhood cancer drugs has actually lagged behind that of adult medicine. Adult medicine or adult chemotherapy, they are now talking about brentuximab and new or targeted therapy or immunotherapy. However, for children, for all cancers in children, irrespective of where they are, most of the cancers are actually the conventional. So when I'm talking about 1970s, I'm saying is that the drugs that we are using are the same conventional drugs that have been there. In terms of role of allopurinol, usually patients with acute lymphoblastic leukemia may present with white blood cells counts in the ranges of 100,000, 150. And when these cells start lysing, when you start giving them chemotherapy or when you start giving them steroids, then they can lyse so fast at a rate which the kidneys are not able to excrete, and this will cause what we call the tumor lysis. So allopurinol comes in at that point is to try and prevent the formation of tumor lysis, which is a metabolic complication that is very difficult to treat when you're starting chemotherapy. So that is the role of allopurinol. Usually you want to give it as soon as you make the diagnosis and up to 10 or 15 days after starting the treatment, when the patient's tumor burden will have reduced. So that is the indication of allopurinol. I will emphasize on the question of PCP prophylaxis. Why PCP and how long do you give the Septrin? So what we are doing when we give patients chemotherapy is we are suppressing their immune system essentially by giving them chemotherapy. So we are inducing an immunosuppressive state the same way as the virus in HIV is inducing immunosuppression in the patient. So for this reason, then you need to protect this patient against opportunistic infection, which PCP is one of them. So as soon as you start this patient on chemotherapy, or as soon as you diagnose the patient, you make a diagnosis, then we usually start them on prophylaxis for PCP using Septrin. For those who are sensitive to Septrin, we use Dapsone. So what happens? They continue with Septrin throughout their chemotherapy until 1 month after the last dose of chemotherapy. The assumption is after 1 month after their last dose of chemotherapy, their immune system has come back to baseline levels and it is able to fight the PCP on its own. So I think those two questions answer the issue of treatment.
Yes, thank you.
And then
just go ahead.
I saw one question that it's important for us to probably highlight. Testis. There's a question someone asked about the testis disappearing. I think this is an important and has an important learning point. So we say that once the leukemia has infiltrated the bone marrow, it will spread to other organs. And what I mentioned, not out of omission or commission, is the lymph node, the spleen, the brain. But in the notes, I actually highlighted the testis. Testis is one of the sites that commonly affected in boys. So we usually teach our students when you think of a leukemia, palpate the testis. So most of the time is that the testis will get enlarged rather than, as the person who was asking the question, rather than it's shrinking in size. So it will increase in size because there are blasts infiltrating that particular area. And sometimes what happens is that we send the patient to the urologist, and if the disease is so severe, they do an orchidectomy. But testis is a very important site for boys for you to examine to see if there's enlargement. Thank you.
Thank you. I've seen a question for asking at what age does it mostly affect, which I'd also like to combine with another one. For acute leukemia, does remission sometimes present with change to chronic leukemia, which may later manifest in the acute phase?
So thank you for the question. So I'll take the first one. The first one is an issue of when does it occur? And leukemia throughout the world is actually thought to occur between the ages of 2 to 5 years, though it can occur in any patient. The most common period of occurrence is usually 2 to 5 years, as we saw in our data. Up to 2/3 of our patients were between actually 2 years and 7 years of age, but it can occur at infancy. It can occur when they are 15, 16, 17 years of age, but those ones are usually less common. Then the second question I didn't get very well in terms of.
The question was asking for acute leukemia, can remission present with a change of it to converting to a chronic leukemia? Okay. Which now in the chronic leukemia may manifest in its acute phase. Okay. I understand it right, yeah.
Yes, I understand the question now. So it's very uncommon, especially in the leukemia is a disease basically of children and young adolescents. So, but it can also occur in the older period. And most of the leukemias that we see in children are usually the acute. So usually they don't change into the chronic form the mechanisms, the pathobiology, and the clinical presentation of the chronic one is very uncommon, and it's more commoner in the adult population. In the 50s, in the 60s, what we see are usually the chronic leukemias. So it's not very common for you to get an acute leukemia changing to a chronic leukemia. However, if we treat a child at 10 years or 15 years and they survive to their 50s and 60s, then it is possible that because of the chemotherapy that we gave or the genetic problem that was there, they may develop another leukemia, which most likely is going to be a chronic type of leukemia. So I think that is the point.
Yeah, thank you. The next question is asking, this is to you, Dr. Gilbert, how early can one know that the child has leukemia? And this is for us, Dr. Austin. There are also children who develop tonsillitis frequently. Is this a red alert? I think we can start with the first part. The first part, how early can one know that a child has leukemia? And then we can cover the tonsillitis part.
Okay. I thought Dr. Austin would check as I take a break, but it's okay. I will answer the question, how early? So as I mentioned, the initial symptoms of, unfortunately, the initial symptoms of acute lymphoblastic leukemia are very non-specific. As we mentioned, the main symptoms that may occur are just general symptoms of fever, hotness of body, anemia, which can always be confused for other things. But what we said is that when you get symptoms that are not resolving after treating correctly, if you treat malaria several times or if a patient comes for transfusion several times, then just look at the hemogram. If you look at the hemogram and this patient has recurrent symptoms and they have a pancytopenia or bicytopenia, meaning 2 or 3 cell lines are affected, then it is likely that the bone marrow is where the problem is, and it's likely that this patient is having a leukemia. So the easiest answer to that question is that it depends on the knowledge of the healthcare provider. If our healthcare provider have a high index of suspicion and suspect a patient has something that is not the normal and it's likely to be leukemia, then we are able to get the symptoms as early as possible. If we not train our healthcare providers or in the communities, in the counties, in the sub-county hospitals, then the delay for in making a diagnosis becomes longer, and these patients will tend to be treated over and over time before an actual or a correct diagnosis is made. Dr. Austin, maybe you may continue.
Thank you, Dr. Albara, for that explanation. In terms of tonsillitis frequency being a red alert, I would say not really, because different patients will present differently and they might have tonsillitis in this presentation. In the next presentation, they have something else. But unless the tonsillitis fits a criteria that we usually call the Paradise criteria, so they have, for example, more than 7 infections in 1 year, then this is a patient who would consider to just do tonsillectomy, especially if now the tonsillitis is exposing them to developing things such as pericarditis, or they're missing school, or now they're having so many frequent throat infections such that they're developing even frequent acute otitis media episodes, which might now endanger their hearing and even expose them to complications, as we've discussed, is when we would now be really concerned. But in any case, if this patient has leukemia and we are planning for surgery, then this patient needs to be worked up quite well. So we have to make sure the HB is at least almost 10, the white blood cell count near normal at least, and even the platelets are within normal limits before we can even attempt to go in for a tonsillectomy. I think I can take in more questions as we allow Dr. Albara to at least take a sip.
Thank you, Daktari, for that thought.
Yeah, okay, thank you both. Maybe we can have a couple more questions that are surgery related. There's a question here actually I wanted to ask. When steroids worsen the immune suppression, because I saw that as part of the treatment for one of the ENT malignancies
For the
associated.
sinusitis.
Yeah.
Yeah.
Won't it
For
worsen?
that, not really, because now what you're doing is you're spraying the intranasal steroid direct into the nasal mucosa. It's being absorbed into the mucosa, but it's not actively being absorbed into the blood. So the steroid only works within the nasal cavity. And these patients actually end up using the steroid spray for even prolonged period, especially patients who suffer from chronic rhinosinusitis. They can use the steroids for 2-3 years even without any issue, which they spray in the morning and evening, or they just do 2 sprays in the morning, and we've never encountered any symptoms of steroid overuse.
Okay, thank you. Just another question about steroid use in these patients.
Yes.
They have, say they're thrombocytopenic, say, in the active phase of disease. And steroids can cause, if I'm not wrong, they can cause like mucosal issues that can result in epistaxis and things like that. I hope I'm not wrong. So how do you go about things like that? Because they impair healing and all of that. Are there circumstances where you've seen issues like that, and how do you address them?
I haven't come across any, but in any case where you have a mucosal injury, or even post-operative patients where we have mucosa that is exposed, there might be some little bleeding. We usually withhold the steroids for at least 1 to 2 weeks to allow time for the mucosa to heal quite well before we reinitiate the intranasal steroids. And during that period, we are actually doing oral steroids. But even these oral steroids, when we give them with a tapering dose. So we might start a bit high, then by the next week when they are continuing with their steroid dose, then we've already halved the dose. And then we will go on, stop them, then now reinstitute the intranasal steroids. From our practice, I haven't come across patients who have had impaired healing from the use of steroids, at least in our post-op patients, or even patients that we are managing as outpatients.
All right, thank you. There's another question here about tonsillitis. So enlarged I think that should be tonsils. Enlarged tonsils, but not inflamed with slight nasal speech. Is that an indication for tonsillectomy? Maybe you can just like appraise us, in as much as this is more about malignancies, the indications ENTs use for tonsillectomy. I think that would be good.
Yeah, so in terms of tonsillectomies, we have something called the Paradise criteria. So the Paradise criteria gives you indications of when now you would want to consider tonsillectomy. In patients, like I've said, who've had like 7 infections in 1 year, those ones require a tonsillectomy. Patients who've had more than 5 infections in the past 3 years, or more than 3 infections in the past about 5 years or so. So these patients are having frequent tonsil infections. They are skipping school. They might even develop febrile convulsions. These are children who are unable to feed. They are going into malnutrition. These are children who have enlarged tonsils that are blocking the airway, so they have obstructive sleep apnea. It's affecting their sleep. They're drowsy during the day. They're not sleeping well at night. They have growth retardation because when they're supposed to be sleeping, when the growth hormone is supposed to be released, they're actively just tossing and turning in bed, struggling to breathe. Then these are children who would want to go ahead and just do the tonsillectomy, given that every other parameter, especially in their blood works, has been met and is within normal ranges. Yes.
Thank you, Austin. There's just a question. This is for myself personally. For adults, is it okay? I know we don't have the growth hormone issues for failure to thrive and all of that, but are the indications for tonsillectomy the same for adults, or does it change? And also risk of bleeding in adults. I'm sorry I've deviated a bit, but I think I'm just curious about that.
I think we might have to have a different CME on tonsillitis and tonsillectomy. But yes,
I totally agree.
the criteria for adults and children is actually quite the same. Still the same. We still rely on the Paradise criteria. Plus, also as an adult, if you find it's just too stressing, you have to miss work. You currently having so many infections. You are unable to feed well. You're in constant pain. You're just having fevers, throat infections. Then yes, would consider tonsillectomy. And also, if or you mentioned about bleeding. Bleeding is usually actually a real concern in adult patients. These are patients who do tonsillectomy, but you might not sleep quite well at night because eventually you might be called that the patient is having some bleeding. But generally, by and large, tonsillectomy in adults goes the same way as in children. First, initially, you would want to treat it as an outpatient, but now if it's becoming troublesome, then now would want to go and do the tonsillectomy.
Thanks very much. I think we'll organize one for tonsillitis as well for adults and children, because I think this is something a lot of us encounter both in inpatient and outpatient management. So it would be a good idea. So there's another question about use of intranasal steroids. So can they be used in patients who are under 2 years of age?
Most companies, okay, I can't mention brands, but most companies that have manufactured the nasal steroids do not advocate for us to use them in children below 2 years at least. Actually, most will say children less than 12 years actually. But sometimes we have special indications where normal conditions that we'd expect occurring in adults are now occurring in children. Like let's say, for example, the patient who now presents with sinusitis and it's a child and they've had like orbital complications. They have the nasal discharge, nasal blockage. We've done the douching. Definitely we'll still institute the nasal spray, but we won't do it as frequent as we would in adults. And for them, then we'd still do the same other managements, maybe add on an antihistamine, of course, do the nasal douching, give our antibiotics before we even consider going for surgery, because sometimes in children, we are able to resolve it with just medical management before we think of instituting surgical management.
Thanks, Doc. There's another question on tonsillectomies. Surely we will arrange one on tonsillitis and tonsillectomies, but Jane is asking, does tonsillectomy really help? Because some patients usually experience tonsillitis-like infections even after the procedure. So does it help patients?
I think those patients are more of developing normal symptoms of an upper respiratory tract infection, where you have some throat irritation, a bit of dysphagia because of the inflammation around the throat. But tonsillectomy actually helps because, at least with tonsils, when we do a tonsillectomy, we're removing the whole thing. So we're removing the tonsil plus the capsule, everything is coming out. We're only leaving a bare tonsillar bed. So there's no more tonsil tissue, which would, and in this case, tonsils, we're referring to the pharyngeal tonsils, because you still have the lingual tonsils that are usually basically at the base of the tongue. So those ones will still be present because you still need some lymphoid tissue to help fight infections around those areas. So tonsillectomy in itself should help, but those patients who continue to develop such symptoms, either the tonsil wasn't removed wholly, which we've seen in some cases, or the patient is just having the normal inflammation and kind of dysphagia around the throat region that would occur with any normal upper respiratory tract infection.
Okay.
Can I just jump in on the same?
Yeah, sure, go ahead.
So thank you, Dr. Austin, and I thank you, I think, for the very interesting presentation. So, and I totally agree, you need to put a teaching on tonsillectomy because the demand is high both from the parents. When we sit in, especially in the private clinics or private patients, the demand is quite high on both the parents and sometimes the healthcare providers to have tonsillectomy as a routine way of preventing recurrent tonsillitis. But the take-home message sometimes is, I think, and you may need to correct me if I'm wrong, is that it will not stop the upper respiratory tract infection. It will just affect the frequent coming to hospital, the not going to school for 2 or 3 days. And then my last comment, if you can, my last point is if you can comment on removing the uvula. If you removing the uvula, is it useful? It's a culture, everyone wants to do it here, and they come to the clinic, they want to have it removed. So probably you can comment on that. For myself.
Removing the uvula is usually kind of like a hot topic. Culturally speaking, yes, people have done it, albeit in means and methods that are not really sterile. So the patients will eventually just present to us with abscesses around the soft palate region, or even an abscess of the stump that was left there. Ideally, I wouldn't advocate for uvulectomy because it has its functions. As you're swallowing, then the soft palate moves up together with the uvula to prevent regurgitation of food or whatever you're swallowing from going up into your nasopharynx and out through your nose, or even up through your eustachian tube and ending up causing middle ear infections. Uvulectomy in itself, I would say, is not it's not an essential procedure, and it's actually quite discouraged nowadays. It used to be practiced a long time ago. We would hear people say, my child is coughing too much, my child is choking, it's because of the uvula, then the uvula is chopped. The only reason I've seen a uvulectomy being done is because the patient had an very long uvula that was actually causing laryngeal irritation. So in that case, not even uvulectomy was done, it was just trimmed a little just to prevent it from causing irritation of the larynx. But otherwise, by and large, I wouldn't advocate for uvulectomy.
Interesting. That's quite interesting. Thank you. I'm sure a few of us didn't even know it has a function. So thanks very much for that. I think it's something mainly people who work in the more like the village areas who see it a lot, because I think I saw a couple of that back in the days when I was in Meru. So it should be like an outreach to let people know that the uvula actually has a proper function in the human body. Thank you very much, Austin. So maybe we can go back to the pediatric aspect of it. I can see we still have a few questions on that. So there's a question here okay, by an anonymous attendee. So with the difference between our local care and the US be lying in the supportive care, hence the difference in outcomes despite the chemotherapy. So, Bara?
Yes, I think this is a very informed comment, and it is 100% true. So in the few years, I think there are people in Kenya who have tried to look at why our outcomes are different from that in the US, the gap that we were talking about. And part of what we presented is what we said. Number one is the diagnosis, but for those who are coming to the hospital, it's not because of the chemotherapy or the difference in chemotherapy, but it's because of the things the patients are not able to complete their treatment because they don't have NHIF. If you have to come to hospital every month for 2 years, at some point it becomes straining. Secondly, is about the toxic death, and that I think that is what you are saying. When we lack chemotherapy, when we lack blood and blood products readily available, when you don't have the right antibiotics. Today I was in another panel meeting where sometimes supportive medications like morphine are not continuously stocked in the pharmacies, so you tend to miss them when you don't have a continuous supply of antibiotics, or when you delay to start antibiotics in a patient who is very neutropenic. These are some of the things that cause actually death and reduce your outcome. So I 100% agree. And in fact, our efforts now are more to make sure our patients have NHIF when they come for treatment, to counsel the parents appropriately on the duration of the treatment, they anticipate the side effects, and then to encourage them that they have to stick to the treatment until the end. the moment they start falling off the treatment, then the relapses become real and become high. Then the other aspect is making our supportive care teams well. We said it's a multidisciplinary, so you need a psychologist to keep, you need a social worker to sort out the financial issues, you need the NHIF on board, and then you need the pharmacist to make sure your drugs are readily available so that you don't miss any treatment. That way, we are going to increase from 25% to 60% without changing any chemotherapy, as the attendee actually asked in the question.
Thanks very much, Doc. Just a random question. Considering most of these studies about chemo on a lot of malignancies are done in the West, so considering the population is white, have you guys tried to compare our outcomes as the Black population vis-a-vis the white population? Is there any difference in terms of outcomes based on the similar regimens?
So thank you. I think that's a very hot topic in international arena, or what we call the global health. Most of the trials of the drugs are actually done in the West, and then most of the drugs are actually being used here, and those drugs are actually being used here without trials having been done here. So there are people who are actually fronting for some of these drug trials, some of these pharmaceuticals to come and do their trials in Africa, so that you're able to see whether the response are the same in terms of the chemotherapy. One of the things that if I may use a simple analogy so that we can remember, is that when we see videos of patients getting chemotherapy in the West, their hair always falls out. Even in TV series, you see that they're bald, they're fall. But then when you come to Kenya in our facilities, patients getting chemotherapy, you don't see such significant or profound side effects of hair falling out or other side effects. So there has to be, and people have tried, actually there are some groups that are trying to look at it, I think in Aga Khan and in probably some MTRH, that are trying to look at, is it that sometimes we are fast assimilators, or we have enzymes that actually take up the drugs much faster than the West? And I think these studies are best done in the adult population, as Dr. Austin correctly said, when it comes to ethics of doing some of these drug trials and studies in children, even for Piriton or areas, the drug companies will say we have not studied children less than 2 years. So I think this should be done on breast cancers, and I think there are people who are looking at it. They should be done on lung CA and prostate or esophageal CA. And then we'll be able to know whether Africans have a different way of metabolizing chemotherapy, and this is contributing to inadequate chemotherapy as compared to the West.
Thank you very much, Doc. I'll just go back to the chat, the Q&A section. There's someone asking why the prevalence in Nakuru region? Is there a study that's been done to look at what is different in that area for those people? I'll just combine it with another question asking why are leukemias not staged? Instead, they're only risk assessed. We have high risk, intermediate, and low risk. So I'll just start with, is there any staging? And if there is no, why is it not staged?
Okay, so thank you for the questions, Daktari. So let's start with the last one. Leukemia is a systemic disease. When I showed you the clinical pictures of it affects all the system. Unlike a local disease like breast, or for example, Wilms tumor, which is a local disease and it's easy to stage as it goes. But leukemia is a systemic disease. So when you have a systemic disease, it's very difficult to stage because the disease is everywhere. So what we use is risk factors, high risk, low risk, or intermediate risk, based on the genetic, based on which type of leukemia, and based on the clinical presentation. So that is the reason why leukemias or blood cancers are not usually staged. Lymphomas are staged because lymphomas usually start from one area moving down to the other area. So that one you can stage. Then in the question, so in terms of the prevalence, so it doesn't mean that Nakuru has more patients. So what we are looking here, remember, is not a prevalence study. These are patients referred to our hospital or to our treating center. So it will depend on awareness of those healthcare providers that are there patient choices. There are many things that make patients probably in Nakuru. Kericho also, we are doing close work and we do these tele echoes or project echoes or discussion with the clinicians there. So when they identify, they are more aware about the signs and symptoms. They refer early because they know this is the treatment center where the patients will benefit. So that is the reason why their numbers are high. It's not that it is more common in the community. For you to determine whether it's common in Nakuru, Kericho, you have to do a population study. You have to go out there in the community and pick 1 million children and find out of them how many patients have leukemia. Go to Nakuru, do 1 million children, and then find how many of them have. And then you can compare. Out of 1 million, Nakuru probably had 20%, but it's very difficult to do that because the prevalence also is not very high. So this is just because of referral or because of awareness of the healthcare providers.
Thanks very much, Doc. There's a question here on how often do we do CSF cytology during the management of ALL?
So I can only talk about our facility or the patients that we do, because that's where I have the information. But CSF cytology is done with every time we are giving intrathecal, which is we are giving medicines through the IT, that is through a lumbar puncture. So we do it with every cycle of chemotherapy. Every week of chemotherapy, they usually get an intrathecal chemotherapy. So that is to prophylax the disease from going into the CNS. And during this time that we are giving the chemotherapy through the lumbar puncture, we also take samples for CSF. So every cycle, because you have to assess whether these patients are developing CNS disease. Remember, we said CNS disease is not very common, only 5%, but along the way, they may actually have the spread into the CNS system. So every cycle, every time you're doing a intrathecal chemotherapy, which is almost every other week, we do a lumbar puncture.
Oh, thanks. I actually didn't know that. Thank you very much, Doc. There's a question here, I think, that reminds me of my pediatric year in undergraduate. So there's a stable looking 5-year-old male noted to be pale. There's no lymphadenopathy or organomegaly. The HP initially was 5.6 grams per DL, transfused 2 units in July, but came back in September with a check HP of 3.6. So the PBF shows features of iron deficiency anemia with target cells, giant platelets, and few spherocytes. This was done after the first transfusion. So there are lower normal WBCs and RBCs. Unfortunately, BMA is not done. A BMA was not done before the transfusion. So the person asking what could be the problem, and is it possible to have BMA done at a county hospital level?
So thank you. That's a very interesting clinical scenario. So unfortunately, it's very hard to pick what specific or the specific diagnosis because we need to investigate this patient further. So I'll start with the last question. The last point, can BMA be done in a county referral hospital? What we are trying to do and what we try to teach is we need to demystify this issue of bone marrow. So this bone marrow should be able to be done in any county facility. In all the 47 county hospitals, we should be able to do bone marrows. In our facility, for instance, bone marrows is done actually by the medical officer or the intern. By the time they are doing their first month of rotation, they should be able to do a bone marrow. Specifically in relation to this patient, when I look at it, this patient is having recurrent episodes of anemia. And as mentioned in our presentation, this is a patient that probably would need additional investigations. So number one, BMA is not contraindicated soon after transfusion, even if we have transfused this patient, because we cannot do a bone marrow on a patient who's severely anemic. So you have to stabilize the patient, then do the investigations. So whether this patient was transfused a week, 2 days or 3 days, we can still do the bone marrow, because the primary aim of the bone marrow is to determine whether there's an abnormality at the level of the bone marrow, at the level where the cells are being produced. The other things that we can still do at this level for this patient has received transfusion, and in spite of transfusion, So either it is a problem in the bone marrow is failing. So there are many syndromes or diseases that are associated with bone marrow failure, or either this patient is sequestering the RBCs in an organ, for example, the liver or the spleen. So those are some of the differentials that when you get the history of this patient, you may need to do. One of the ways that we can do is do a peripheral blood film to look for things like target cells. You say they were already target cells, but also things like, are you seeing sickle cells? Are you seeing signs of hemolysis? Because I think this patient most likely is having a hemolytic process rather than a bone marrow failure syndrome. And then you can do with other things like your bilirubin levels, the LDH levels, and what is important, the reticulocyte count. Because if the reticulocyte count is normal, it means the bone marrow is functioning. So it means the bone marrow is compensating to try and replace the low HB on its own by producing more red blood cells. So it means the problem is not at the level of the bone marrow, but probably something in the system. It could be hemolytic anemia, and highly likely this patient could be having a hemolytic anemia. If it's not a hemolytic anemia, then it could be a congenital or bone marrow failure syndrome, which there are so many apart from a lymphoproliferative disorder. So I think that is how I would approach the patient: do a peripheral blood film with a reticulocyte count, an LDH, and a DCT. Then once your patient is stable, do a bone marrow. Those tests will be able to tell you whether they are blasts, whether it's an abnormal hemolytic process, or whether it's a leukemic process.
Thanks very much, Doc. I think we're almost running out of time. We have 2 minutes. So I'll just pick one of the questions remaining, because I'm seeing, I think the others probably were covered during the presentation. And I really hope you and Austin are comfortable sharing your presentations with us, and so that we can share them with the attendees. So, okay, there are actually 2. There's a question on rickets. Does it have any association with leukemia at an early age? And the other one I'll ask is, can leukemia be prevented? So I think those are our 2 last questions. Then after this, we can wind up. And then we'll see if the presenters are comfortable sharing their presentations with us. We'll get them and share them with you. And also there's a recording which we can share with you at a later date, so that you can go through it and just check whether the non-answered questions have been covered. So thank you. Dr. Olbara, maybe you can answer the last 2 questions.
Thank you, Doc. So, rickets has no association, or is not associated with leukemia. And I think that's the simple answer for that question. It has no association with leukemia. It's only that the manifestations of rickets can also mimic those of leukemia. And leukemia also can mimic manifestations of rickets. Why I say this? Remember, rickets is because of hypocalcemia. Calciums are one of the most important immune modulators in our body, in terms of the ciliary mechanism, in terms of immune or movement of the neutrophils. So sometimes these patients with rickets tend to have these persistent fevers, they tend to have recurrent infections, they tend to be wasted, or so they may have signs that initially you can confuse with leukemia. Remember, we said also in leukemia, you can have bone pains. Patients with rickets can also have bone pains. In terms of associations, they don't have any association. In terms of overlap of clinical symptoms, yes, you can actually confuse rickets for leukemia and vice versa. Some of the signs of leukemia can actually be confused for rickets or osteomyelitis, especially when bone pain is the only manifestation. Then, can leukemia be prevented? We don't know the cause 90% of the time, so it's very hard to prevent leukemia in children. There's no known cause, so you can't prevent something that you don't know.
Thank you so much for the presentations from both Dr. Olbara and Dr. Austin. I really appreciate you guys taking the time to do this with us. So as we've said, we will organize a CME. I will push the research team of KNH. We organize a CME on tonsillitis, and basically, I think, upper respiratory tract infections for us to cover with Dr. Austin. So thank you all for attending. The CPD points, I think, will be allocated. I'll leave that to the research team to answer. And let's keep showing up for these things because they're good for ourselves and also for our patients. So thanks very much to the presenters. Thank you for the attendees. I think if the research team has anything to say, maybe we can let them speak for a bit and then now we can close the meeting. Thank you, everyone.
We thank everyone for attending this webinar. We will follow up on the CPDs.
Thanks very much. I think we can end the meeting there. Asanteni sana.